Thank you, Chairperson. Thank you, Abhay, for the kind introduction. This topic was supposed to be taken by Dr. Nadima from Jordan, but she could not make it, so that's why I am filling the gap. So I shall be telling you about the gestational diabetes, challenges in management, what could be the alternative to the insulin. Because insulin therapy also remains the challenges in the treatment of the gestational diabetes. Manifestation of the glucose intolerance in pregnancy, often named as the gestational diabetes mellitus, is emerging as a major public health problem not only in India but across the world. IDF 2021 say that global pooled prevalence of gestational diabetes is estimated to be 14%. In the Southeast Asia, IDF reports that 1 in 4 live births is affected by the hyperglycemia in pregnancy. A systematic review and meta-analysis estimated the pooled prevalence of the GDM in India to be 13%, although it is quite variable when we move from north to south, starting from the 4% in J&K and 16 to 18% in Tamil Nadu. So when we talk about the gestational diabetes or hyperglycemia in pregnancy, the things arising in the same fashion as it remains, it is out of the pregnancy. Insulin resistance is a need of the pregnancy. Insulin resistance is a thing which is welcome in the pregnancy. For that, it is a mother is able to make the child's body get the fat deposition on the fetus, and this helps in developing the fetus. But once it becomes too much high that maternal pancreas is not able to handle the challenge of the insulin resistance, it converts into the hyperglycemia in pregnancy. And when it happens, it is also associated in the adipose tissue dysfunction, gut dysbiosis, liver dysfunction, skeletal muscle dysfunction, what the things are usually seen when insulin resistance is rising out of the pregnancy. And this hyperglycemia in pregnancy is responsible for maternal and fetal complications. Not only the complications, but also we can see the next generation risk for the type 2 diabetes. When we talk about the risk factor which may be posing a larger challenges in patients with the gestational diabetes, of course, that could be the family history of diabetes, previous gestational diabetes history, multiparity, high blood pressure, advanced maternal age, overweight, obesity, PCOS, ethnicity, especially the Asian ethnicity, previously macrosomic baby, which have been having the weight of more than 4.5 kg. So what is the biggest challenge while managing the pregnancy? St. Vincent Declaration says that achieve a pregnancy outcome in a diabetic woman that approximates that of the non-diabetic women. And this is the biggest challenge in the given condition when we really need to have a baby of the optimum weight between 2.5 to 3.5 kg, which may not get any complications in the future life. So managing GDM not only saves 2 lives, but also it is important primary prevention of type 2 diabetes in next generation. It helps in identifying mothers, those who are more vulnerable to become the type 2 diabetes in their future life. And of course, it reduces the occurrence of type 2 diabetes in generation to come. So this is the biggest advantage of treatment of the gestational diabetes if we can really do that. What could be the target blood glucose levels? Of course, the fasting level should be 90 milligram or less than that. Postprandial level should be less than 120 milligram. Mean plasma glucose level should be around 105 milligram per deciliter. And if it can be managed, then we can expect a mother is delivering a child between 2.5 to 3.5 kg, which could be a step to prevent the offspring which may not develop the type 2 diabetes in the future life if her birth weight will not be less than 2.5 or more than 3.5. What we could see that hyperglycemia brings preterm delivery. Even the percentage of the preterm delivery increases with the increasing hyperglycemia as the pregnancy duration increases. ADA 2018 has recommended that HbA1c target in pregnancy 6 to 6.5%, but if it could be managed less than 6%, it may be optimal if without significant hypoglycemia, but relaxed to up to 7 if necessary to prevent hypoglycemia. So this is the HbA1c target less than 6, but even at 5.5, we can say some sort of the preterm delivery could be seen. Glycemic targets in women with diabetes are really a challenge because we need to manage the fasting glucose less than 95 and 2 hours postprandial less than 120. With multiple organizations are saying little bit different, but more or less the targets they are having a consensus of this sort. So glycemic control should be assessed every 2 weeks at the diabetes clinic whenever a person, a lady is in the pregnancy. Hyperglycemia at the conception is also associated with risk of congenital malformation. And this is another challenge. And this actually gives an insight us that we should do the screening of every mother who is going to be pregnant. So pre-pregnancy screening of every mother, whether she is diabetic or non-diabetic, is most needed. Unplanned pregnancy should be discouraged, and many times it happens because of lack of awareness. Women and their family members don't know the consequences of the gestational diabetes, and they enter into the pregnancy without knowing the status of their insulin resistance, without knowing the status of their glucose intolerance, and many a times maybe obesity, which may lead to the insulin resistance rising very fast, may not be handled well by the maternal pancreas. So limited knowledge about the self-monitoring of the blood glucose, dietary control, physical activity, lack of education regarding the postpartum screening. So a lot of things are there which may be the challenges as far as the self-management of the pregnancy with diabetes is concerned. A lot of myths and taboos are also responsible for this mismanagement, like some people believe that exercise may be the harmful during the pregnancy. Pregnant women should be eating for 2%. This is a common misnomer and common myth among many families that if a lady becomes pregnant, she should double his food. Family fear that taking insulin is another myth which many people think that if we shall be injecting the insulin in the abdomen, it may harm the existing fetus. So family influence often overrides the medical advice, leading to non-adherence to the diet and treatment plans. Poor compliance with the lifestyle modification. Financial constraint many of the time is also responsible for the adhering to the management strategies what are advised. Many of the times in rural areas, women have to travel long distance for GDM screening and care. And because of the limited availability of the trained phlebotomist and standardized laboratories, many times it may not be possible to take the fasting and PP board. In such condition, the DIPSI has suggested that if we can take a single step procedure in antenatal clinic, a pregnant woman is given 75 gram oral glucose load, irrespective of whether she is in the fasting or non-fasting, without regards to the time of the last meal. GDM could be diagnosed if the 2 hours plasma glucose is equivalent of more than 140 milligram per deciliter. At the healthcare provider level, what could be the challenges? Of course, multiple guidelines creates a lot of confusion among the healthcare professionals, and they are not really having their mind made up what to treat and what level should be targeted and how to treat. Universal screening is not widely implemented most of the time, and many pregnant women are not tested at early enough. Lack of the training for the healthcare providers may also be responsible for not diagnosing the GDM at appropriate time. Poor coordination among the doctor and patient may also be responsible for the poor follow-up and not appropriate postpartum care. And many of the time, patient may not be compliant to the advice what is being given by the healthcare professional. Need for a multidisciplinary approach is very much needed, but sometimes our system is not so much aligned that obstetrician, diabetologist, and nutritionist and primary healthcare worker may come in the close coordination. Many of the time, there is no standardized referral system, which is resulting into the fragmented care. So recommendations to address the challenges, how can we really address these challenges? Of course, we can conduct a public health campaign to educate women about the GDM. We can ensure that all pregnant women should be screened. Universal screening should be tightly implemented. A standardized guidelines must be there. There may not be any confusion among the healthcare professionals. We should have the training program for the healthcare professionals, integrate the GDM management into the existing maternal health programs, and provide free for subsidized glucose testing and insulin, and of course, the establishing the routine postpartum screening program to prevent the progression to type 2 diabetes, which is the most important. So why screen if we cannot follow up and manage? Then this follow up and management remains the problem in the developing countries, especially like India. Many of the times, the developed country in the Asia like Singapore, there are the barriers to gestational diabetes management and preferred interventions for the women with GDM when working women are reported to have the barriers to the GDM management when they do not have the reminders for the blood glucose monitoring. They may not be having the appropriate reminders for the diet control, insufficient time for the exercise, and so many other excuses remains there. 80 to 90% women with GDM could be managed effectively by the medical nutrition therapy, in which we can give the appropriate diet plan and exercise to handle it GDM without any help of the pharmacological intervention. Women with normal BMI should have the recommended weight gain to 11.4 to 15.9. Who are overweight, they should be allowed to gain the weight 6.8 to 11.4, and obese women should not gain weight more than 7 kg. For women at high risk of the excessive weight gain, intervention need to begin in the first trimester. Weight gained in the first trimester is more predictive of the infant weight than the weight gained in the third trimester. So if weight gain in the first trimester is more, we are having the enough opportunity to stop it so that the fetus may not become the macrosomic. No increase in the calories in the first trimester is advised, so we should not follow the pregnant women should eat the double or eat for the two. An additional 340 kilocalorie during the second trimester can be added, and 452 calories during the third trimester could be added. Recommendations for the treatment of the GDM: most women can manage the GDM with the lifestyle intervention, I say 80 to 90%. But if it is not, but after the 2 weeks of the trial of the medical nutrition therapy, it is mandatory to either start on the insulin or go for the oral hypoglycemic agent. Now question arises, insulin always remains a challenge most of the time. What could be the replacement of the insulin? Do we really go with some oral hypoglycemic agents safely? Of course, the metformin have been found to be very much useful and benign as compared to the other oral agents if the insulin is not the option or the insulin is not accepted by the patient. It improves the insulin sensitivity, has the lower risk of the maternal weight gain, hypoglycemia. But one thing we should not forget always, that insulin resistance is the basis or physiological need of the pregnancy. Metformin reduces the insulin resistance. We should always be careful that it may lead to the low birth weight, it may lead to the failure of thrive to the developing fetus. So when we talk about the metformin, it could be effective in preventing adverse perinatal outcomes, may even have possible benefits in the long term. A lot of randomized trials has supported that metformin could be useful, and when the metformin has been added up to the treatment, it has been found the probability of the insulin initiation could be lesser than as compared to the placebo. A meta-analysis of the metformin and insulin has proven that metformin demonstrated a significant reduction in the risk of the preeclampsia, induction of the labor, cesarean delivery, macrosomia, neonatal intensive care unit, and admission to the ICU and neonatal hypoglycemia. Alternatives to the insulin, another alternative could be the glyburide. A lot of trials has been done, but not in India. Most of the studies are from the Israel and other parts of the world. Langer has done a lot of studies about the glyburide. It does not cross or crosses very little to the placenta. Metformin crosses the placenta. This is the difference between these two molecules. So if we talk about the oral hypoglycemic glibenclamide, the use of the oral glibenclamide for the treatment of the GDM is alternative to the insulin therapy because of the similar glycemic control, ease of administration, and better patient compliance. But hyperinsulinemia is a thing which arises because of its use, this particular sulfonylurea, and many a times it becomes the reason of the abortion. Another alternative, the acarbose, which could be tried. A lot of people have started, but no recommendations are available by any authority, and we do not have the randomized control trial for the acarbose. So limited evidences are there, but it is effective in mild GDM because postprandial hyperglycemia is the problem with the with the GDM. So it could be corrected with the acarbose. It causes some GI effects like bloating and diarrhea, and safety data are not available. So as far as the recommendation is concerned, insulin, of course, the first recommendation followed by the metformin and glyburide could be chosen, but acarbose is having very little data. So take home message, GDM poses a significant risk to both mother and fetus, including macrosomia, preeclampsia, and neonatal hypoglycemia. Early diagnosis and intervention through medical nutrition therapy, lifestyle modification, pharmacotherapy are crucial for improving maternal and fetal outcome. Insulin remains the gold standard for pharmacological management, providing tight glycemic control without crossing the placenta. While metformin crosses the placenta, glyburide also crosses the placenta, but lesser than the metformin, having the convenience and affordability among the population, but their use should be individualized due to the concern over the placental transfer and neonatal effect. Postpartum follow-up is essential as 50% of the women with gestational diabetes develop type 2 diabetes in their later life within 5 to 10 years. Long-term maternal and fetal monitoring is key to preventing future metabolic disorder. Thank you very much for your kind listening.